What is ventilator and why is it required at all in ICU?
They are lying on the bed for a long time. It's a lot of discomfort, so they tend to get into panic.
Someone is on ventilator, does that mean he's dying?
That once the patient is on ventilator, he's gone now. He's not going to come out. Let's pray.
Why a patient needs ventilator? Can you tell me few reasons?
Failing to provide adequate oxygen to our body or to remove carbon dioxide. This is the primary function of lungs, to get oxygen to the body and remove carbon dioxide.
You can talk with the relatives, convince them and put the patient on ventilator.
How would you know that now it is the time to take off the ventilator? What
is he breathing at all? How does his breathing works then?
So when they regain consciousness, they see a tube in their throat, so many tubes here and there in the body.
In coma is same as being on ventilator? Are these something too different or these are the same terminology? Namaste everyone, I am Dr. Amitabh Kulkarni. Welcome to today's podcast. Today we are going to discuss about a very sensitive topic related to critical care. I am very happy my friend Dr. Rajesh is there with us today. He is a consultant critical care and he has been practicing in Dubai for last 6 years. Today he is going to share some details, burst some myths and clarify some doubts related to ventilator. Welcome Dr. Rajesh to today's podcast. Can you tell us about yourself?
Yeah, hi everyone. I am Dr. Rajesh and thank you Dr. Amitabh for inviting me here. I am a consultant critical care medicine and I have worked in India and in Dubai. My total experience is about 15-16 years in critical care medicines, where critical care medicine means working in ICU. So the most dreaded and most I would say the modality of treatment about which people are afraid is the ventilator, which is being used in ICU. And today we will be discussing about that, and I'm sure many of the questions and anxieties of the people will be able to resolve today.
Yes, thank you for the introduction, Dr. Rajesh. Now let us start with today's discussion. Now coming to the basics of ventilator for a general person. What is ventilator and why is it required at all in ICU? Can you tell us about that?
Yeah, very good question. As the name suggests itself, ventilator means something which is ventilating. Ventilation means breathing. So any machine or a device which is helping a person breathe is called as ventilator. It is required of course in patients who have difficulty in breathing. There are different indications, different reasons why patients are being put on ventilators.
So coming to the reasons why a patient needs ventilator, can you tell me few reasons in which situations patient need ventilator so that you can talk with the relatives, convince them and put the patient on ventilator? Can you share some indications for ventilator?
So most common and primary reason for putting a patient on ventilator is the respiratory failure. Respiratory failure means the respiratory system is the one system of our body involving lungs which is responsible for respiration. When they fail, when this system is failing to provide adequate oxygen to our body or to remove carbon dioxide, this is the primary function of lungs, to get oxygen to the body and remove carbon dioxide. When this system fails, it is called as respiratory failure, and to support the body when this system fails, put the patient on ventilator. But this is not the only indication. There are other reasons also when we put the patient on ventilator in other than the respiratory system. Suppose a patient who is very critical, a patient whose blood pressures are very low, he is so sick that the risk of death is very high, and he is on multiple medicines to support the blood pressure. At this moment, we do not want patient to spend his energies on his breathing. We must understand that to perform normal breathing, body spends 30% of the cardiac output, 30% of the functions of the heart, the pumping of the heart, or 30% of the blood goes to the breathing system when in normal circumstances. In shock situation, this load on the heart increases. So to prevent this load to get onto the heart, we put the patient on ventilator so that at least one system we have secured, and the rest of the blood flow and rest of the energies of the patient is spent in his healing or the perfusion of other organs which cannot be supported directly. And there is one more indication which is also common, primarily in neuro patients, patients who are unconscious, who are comatose. These patients, they are unable to swallow their secretions. Like normal people, when we are conscious, we spit out the secretions, we clear our throat. nothing, no saliva. 1.5 liter saliva is secreted from our mouth daily. So usually we swallow this secretion, we don't realize this, it's 1.5 liter. So a patient who is comatose, he doesn't have these reflexes to swallow these secretions. So what happens, he starts pooling these secretions here in the throat, and slowly these secretions trickle down into the lungs, and then later they can cause pneumonias, which can be a much bigger problem. So these patients also, prophylactically we put them on the ventilator support.
Yeah, that's a very simplified understanding for ventilator. Now coming back to the sick patients which you just described. So for common people, there is another term called coma. Is the patient in coma is same as being on ventilator? Are these something too different, or these are the same terminology?
No, these are completely different terminology. A patient who is in coma may be on ventilator, but all the ventilator patients are not in coma. Most of them are not in coma, but possibly you will find them sleeping most of the time. But that is an artificial sleep which we induce, because to put the patient on ventilator, we have to put a tube in their throat. The tube goes through the mouth, covers all the soft tissues of the throat, and it reaches into the trachea, windpipe till the chest level. So it's a big amount of discomfort which the patient has. To allay that discomfort, to relieve that pain and anxiety, we keep these patients sedated so that we can ventilate them properly.
So you mean to say you give some injections so that they are sleeping while they are on ventilator?
Mostly yes.
Yeah, that's very good. One more basic question about ventilator. When someone is already on ventilator, he is sleeping artificially, is he breathing at all? How does his breathing works then? What is the process?
Yes, so these patients, most of the diagnosis nowadays with the recent advances in the medicine and critical care, we promote self-breathing. If we don't allow the patient breathe, then their muscles starts getting atrophied. So we allow them to breathe as much as they can. If they are extremely sick, or they are not at all able to breathe on the ventilator, they are not able to coordinate their breath with the ventilator, then only we sedate them very deeply, we paralyze their body so that we can ventilate properly. But in all other circumstances, we give a light sedation where they can breathe on their own, and the ventilator just support them to some extent, and that extent depends on the disease pathology, how much they are sick.
Okay, yeah, that's very clear now. So is being this is for general understanding, is being on ventilator very painful, uncomfortable? Because that is usual people's perception. So is it really painful a process being on ventilator?
It's a discomfort. Rather than pain, I would call it a discomfort, because there is a tube in the throat and the air is being pushed through the ventilator, and the patient has to coordinate with the machine's breath. So more than pain, it's a discomfort. That's why we sedate these patients. We are giving them anti-anxiety or some sedatives, some painkillers, mild, as per the requirement of the patients, so that they can coordinate or coordinate with the ventilator.
So that means you want them to try on their own, so you don't completely paralyze them, completely comatose them, and you want them to make some effort so that slowly when they are recovering, they will also start breathing on their own, getting back to the normal.
Yes, as a protocol, we daily give sedation breaks in the ICU. In the morning, before the morning round, we stop all sedation, we let the patient wake up, and we see how he is behaving, how he is coordinating with the ventilator. So that's a usual protocol which is being done in all ICU.
That was very clear and crisp. Now, how long someone can stay on ventilator? There are various misconceptions that once someone is put on ventilator, they're not going to come back, or whatever happens to them. From your vast experience, how long a person can stay on ventilator?
Yeah, that's a very good question actually. This is the anxiety of most of the family members whose relatives are on the ventilator. Then doctor, how long are you going to pull this? So the reason for putting on the ventilator, for whatever reason we are putting it, that reason should have been treated. Suppose we have put the patient on ventilator because of some lung infection, pneumonia. So once the pneumonia is treated, then we think of removing the ventilator. We will not remove as per a deadline, like for the next 5 days. It's not a medicine which has a course of 5 days or 7 days. It is a supportive treatment which is given to the patient to sustain his life. It's a life support system. But we have to treat the cause because of which the life is a threat.
Correct.
So once that cause is treated, then we remove the ventilator. If it is taking a very long time to treat that cause, we'll keep that ventilator for a very long time. So there is not a fixed deadline. Some patients are being kept kept for hours only, some for days, some for weeks, and unfortunately in some patients it extends to even months also.
Yeah, so this is a very important clarification our viewers need to understand, that if someone is on ventilator, he is not going to be forever on ventilator. It is a temporary support till his overall condition improves, he starts breathing on his own, so that once his primary disease is under control, when he is breathing on his own, ventilator can be safely removed. Now coming back to the ventilator, another common concern, are there any risk of being on ventilator? If someone is on ventilator, are there any side effects or any hazards of being on ventilator, even whether it is for a short period or a prolonged period? So what do you say about this?
Yeah, see, it's an invasive therapy. It's not something non-invasive. It's an invasive therapy, and we are putting a tube in the throat into the windpipe, and then we are forcing air into the lung, which is a positive pressure ventilation. Normally, normal physiology, normal human body, we take negative pressure breath.
Correct.
We generate negative pressure in our throat, and we suck in the air inside. And for pushing out, we have to use our muscle. So expiration, breathing out is positive pressure, breathing in is negative pressure. But in these patients, on ventilator patient, it is reverse. Pushing in air is positive pressure and bringing the air out is spontaneous.
Correct.
So it's a reversal of the physiology. So it has effects on the body. There are some effects on the body. That's why we don't put every patient on the ventilator. There are certain indications only when we put them. We do it when it is absolutely necessary for the patient. So whatever physiological effect the ventilator is causing, that doctors and the treating team is aware of, and adequate measures are taken every time the patient is on the ventilator. First thing. Second thing, because it's an invasive procedure, there is a risk of infection anytime.
Correct.
This patient is not able to cough out on its own. He is sedated. So we have to put a catheter into the lungs and we suction the whatever secretions are inside. Yeah. So on the one hand, we are removing whatever infection was inside through in the form of secretions, but we are putting a source of infection again.
Correct.
So that is the risk which he has. These patients are also on the risk of something called as ventilator-associated pneumonia.
Correct.
It's a known phenomena. We can reduce the incidence, but it's a worldwide known, even in the best of the ICUs in everywhere in the world, this happens, but we can keep it under check. There are measures to control it so that the incidence is minimal. All these measures are taken in our ICU, and I believe in every ICU worldwide.
So I'm sure this must be a challenging task for you to someone putting on ventilator and explain to them about the risk hazards of ventilator. But remember, viewers, this is a life-saving treatment, so some risk may be associated with it, but you need to understand and accept. So coming back to the next common questions are there, that if someone is on ventilator, does that mean he's dying, or he's like very sick and he's not going to come out of this?
Yeah, this is one of the most common belief in the society, that once the patient is on ventilator, he's gone, now he's not going to come out. Let's pray, give last prayer. So this is not true. This is a myth.
Correct.
Because most of the patients nowadays, with modern medicines and modern ICU care, most of the patients who are on ventilator, they come out.
Okay, that's a very good sign.
Incidence of patients who are dying on ventilator is very less, and these are the most critical patients.
Okay.
And ventilator is a therapy which can save them. But medicine is still an ongoing process. It's not 100% reversal, but there is a fair chance, good amount of chance that the patient comes out of the ventilator.
So all of us should understand that if someone is put on ventilator, this is the common question, he is not going to survive now with just some counting days. No, it's not like that. Most of the patient, as Dr. Rajesh says, do come out of the ventilator. Yes, of course, there are very critical patients whom it becomes a challenge. But don't presume that if someone is on ventilator, that's the end of the road. Now coming back to another important question which most of the patient ask is, can he eat when he is on ventilator? Because this is food and diet is something very close to patient's sentiments. So if someone is on ventilator, whether it is for short duration or for long time, can he eat when he is on ventilator?
Yes. The answer is yes. We can provide nutritious support to the patient, but because there is a tube in the throat, it won't be possible for the patient to have the food like the normal way we
Understood.
eat. But what we do, we put a tube to the nose or the mouth, and the tube goes directly into the stomach, and
Rice
through the
tube,
tube, rice tube. It is called as rice tube, and we feed through the tube. There are formula feeds which calculated proteins and calories as per the patient's need and his diagnosis and his disease. The dietitians do regular follow-up and they prescribe a certain amount of calories and proteins and vitamins, minerals, which we give through these tubes. And then there are patients who cannot be fed through the gut through the normal path, like if the patient has some problem in the intestine itself,
Yeah.
so they won't be able to digest that food. So we cannot feed them through the normal intestine. We give the injections through the intravenous route to the neck. There are parenteral solutions which provide nutrition. So for those patients we give nutrition through the intravenous, like directly into the blood.
Okay, yeah, that's very clear. So, even if someone is on ventilator, his nutrition is not interrupted. It is continued in ICU. What happens if someone suddenly, if something goes down or breaks down the ventilator? If suddenly ventilator stops working and he is already on ventilator, this must be a very uncommon situation. But if it comes, maybe whether it is due to power failure or some problem in the ventilator, so what do you do in such situations?
Yeah, so the whatever ventilators we have in the ICU, they are regularly checked, and before starting the ventilator, there is a pre-use checklist.
Correct.
And the ventilator is put on the self-test mode.
Yeah.
When all the tests are positive, then only we connect to the ventilator.
Okay.
And these are regularly maintained.
Okay,
And all the ventilators have power backup. Even if the power goes off,
That's very
they have
reassuring.
backup batteries. Not even one, now two batteries are there in every ventilator. So though I have in my career I have not seen till now any ventilator dysfunction, but even then we always have a backup ventilator available in the ICU. In that case, if there are alarm systems on the ventilator. If anything is dysfunctioning, if we suspect that there is some problem in the ventilator, it gives alarm. We check. If we find that this is something which needs more attention, we change the ventilator. So there is always a backup ventilator. It doesn't happen that ventilator will stop suddenly. There will be some alarms or something. So even if there is a suspicion or dysfunction, we change that ventilator and we check the other system.
Yeah, that's very reassuring to know that there is always a battery backup in the ventilator, and even if it breaks down for some reason, we still have some backup ventilators. Dr. Rajesh, there is one more term which I had heard, and that is ventilation-induced lung injury. For my understanding, ventilation is used for lung injury. So how can ventilation can still cause lung injury? Is it like a misnomer, or is it a complication? What exactly is it related to ventilation?
Yeah, as I told before that it's the physiology is reversed. Now we are pushing the air into the lung rather than negative pressure. So this is against the physiology. So what happens? Their body reacts to it in some way. This whatever way the body reacts, it's called as ventilator-induced lung injury.
Okay.
This can happen because of the over distension of the lung. Because now we are pushing the air a definite amount of tidal volume. When we are normally breathing, sometimes we take small breaths, sometimes we take larger breaths. And now we are ventilating a already compromised lung, already inflamed lung, infected lung. So when we are pushing air into the lung, sometimes this infected lung area may get over distended, and the normal may get under this, and the normal area may also, because it is more compliant, it may hyperextend. So this may cause stretching in the lung, and because of the stretching of the lung, some chemical markers are released into the blood, which can cause inflammation in the lung.
Okay.
That is called as ventilator-induced lung injury. But with the scientific research and recent evidences, there are methods of ventilation which reduce the incidence of ventilator-induced lung injury. These are called as protective lung ventilation strategies. So nowadays, whenever we apply ventilator support, we use the protective lung ventilation strategy so that this incidence is minimized.
So is it a cause of worry if someone gets a ventilation ventilation-induced lung injury?
I don't think so, because nowadays we are using all the time protective lung ventilation, so the incidences are very less. But yes, it is there. It's a known complication of ventilator, which can happen actually. But we can minimize the incidence by using the scientifically proven strategy, which is protective lung ventilation.
Thank you for the clarification. Now coming back to something important in ventilation, how do we recover from ventilator? We did hear from Dr. Rajesh why do we start someone on ventilator, what are its effects, side effects. Now if a patient is recovering, then what is the process? How do a patient come off ventilator? Like can you just tell us in simple language?
Yes, this is the question mostly our patient's family asks, that how would you know that now it is the time to take off the ventilator? How would you know? Because the patient is sedated, is already on the ventilator. So when will you remove it? So as I told earlier, the first step is the cause of the reason why we put on the ventilator. That reason should have been taken care of. Suppose if the patient was requiring some surgery, that surgery is already done. This is the reason we remove the ventilator.
Correct.
Similarly, if a patient had an infection in the lung, suppose we saw in COVID time, he had COVID lung infection. So when the lung infection started decreasing, it is shown on the X-ray, it is shown on the blood parameter, and we also see that on the ventilator parameters. The pressures on the ventilator, the amount of tidal volume he is receiving, the compliance of the lung which we assess on the ventilator starts improving. So by looking at the multiple parameter, we decide that it is the time to withdraw the ventilator support. But the reason for which, the first criteria is the reason for which he was put on ventilator, that should have been taken care of. After that, there are certain markers, different parameters which we assess, and we plan the weaning of that's called as weaning. Weaning of the ventilator is started, and it is done by spontaneous breathing trials. We stop the sedation, we give them a trial of spontaneous breathing. We put the patient there. In the ventilator also there are different modes. There is a mode which is called a spontaneous ventilation. We put the patient on spontaneous ventilation mode, and we assess for next half an hour or 2 hours maximum that how the patient is breathing. If the patient is able to breathe normally during that time, then we remove the ventilator support.
So good to know that. Do all patients come out of ventilator? We have heard some of the celebrities are on ventilator for long period. So in your experience, what is the scenario like? Do most of the patient come out of ventilator?
Yeah, most of the patient if the cause for which the patient was put on ventilator is treated, it is treatable, then the patient do come off the ventilator, and most of the patient nowadays are coming out of the ventilator support. But sometimes these patients require prolonged ventilation. Some of the diseases, like a patient who had a stroke, he is going to be major stroke, he is going to be in a coma for a very long time. Maybe 6 months, maybe 1 year, maybe even more. So for these patients, we can remove the ventilator, but this tube we cannot remove, which is in the throat, to protect the airway. Like I told earlier, saliva can go inside. So there is an alternative which is called as tracheostomy, which we do instead of this long tube, we put a smaller tube directly through the neck. We make a small cut here and put a tube directly through the neck. We can remove the ventilator, we can remove the mouth tube. Patient is more comfortable here because it's not disturbing his oral cavity. So with this tube patient can stay for a long time. Ventilator can be taken off, put again, depending upon the need. So this is what we do when patient requires long ventilation.
So that was actually my next question. You answered partially. Tracheostomy. What is tracheostomy, and do you do it in all patients, or only specific group of patients you identify and do tracheostomy, and how long can it be kept, like tracheostomy?
So tracheostomy is a process, is a procedure. Stomy means a hole, and trachea means windpipe. So we do make a hole in the windpipe, that's tracheostomy, and through that hole we put a small tube inside. See, when we put the patient on ventilator, initially we put a tube through the mouth. It's a long tube compressing all the structures in the mouth, going into the windpipe till here. Now if the patient is not coming out of the ventilator for a long time, usually we do it after 2 weeks. But if we can see that this disease is going to take long, we know that the patient is going to be comatose for 6 months or 8 months, then there is no need to wait for 2 weeks. We can do it even earlier also. How it is done? It's a small surgery. We put a nick here, a small cut here, insert the small tube,
Right.
under bronchos camera guidance, and with this tube patient can stay for a very long time.
Yes.
Even lifelong also patient can stay with the tracheostomy.
So that's a good to know that not all patients require tracheostomy, but whenever it is done, it is for patients' benefit. The feeding is better, the oral toilet is better with the tracheostomy. So now coming back to last couple of questions. One is it like it can cause a long term damage to your lungs or body if someone is on ventilator for like say a month, 2 months or more than that. So does it cause any harm to the lungs per se or to the body overall?
This is an artificial process. This is not natural way of breathing. So if we continue the patient on ventilator for a long time, it do have some repercussions in the body.
Correct.
Especially the muscles, respiratory muscles, because we are forcing the air inside. The respiratory muscles tend to get weakened. The exercise of the muscles is less, so the muscle atrophy starts happening. So the patient who are on the ventilator for a long time, this is something called a diffuse atrophy or diaphragmatic changes and the respiratory muscle weakness. This may happen. So these patients may become ventilator dependent also.
Okay.
So that's why the idea is to give daily sedation. That's what I mentioned before. We give stop sedation daily in the morning so that patient can breathe on his own, use his respiratory muscles, and that's why we don't sedate them very deeply. We want them to breathe so that their respiratory muscles are engaged and they are trained. And but if you don't do that, then yes, the respiratory muscles can get weak, and the patient can become ventilator dependent.
Now coming back to the final question for today's podcast, and it's more of an emotional question. How can their family? I know you as a doctor, physician, intensivist are doing the toughest job, but how can a family support if someone is on ventilator? They can't communicate with them, they can't talk with them. So what is your advice to the family if someone is on ventilator? How can they support?
Yeah, my advice would be that these patients, although they are sedated, we never sedate them too deep. Okay, so they may be listening. So whenever the family goes near to the patient, they should give positive reinforcement to the patient.
Very good.
They can tell them that they are with them. The whole team of doctors and nurses are there to take care of them, and this is a treatable disease and he can come out of this.
Correct.
So because the patient, sometimes they are not even aware when they are put on ventilator. So when they regain consciousness, they see a tube in their throat, so many tubes here and there in the body. They are lying on the bed for a long time. It's a lot of discomfort. So they tend to get into panic. But if they already know that the family is around and family, they can sense that the family is calm, that means that things are under control. If they see the family also panicking, then the patient may get even double panic. So it's better to be calm and composed when you go near the patient. Even if you think that he is not listening, speak. Tell the patient that everything is under control, you are improving, very good team of doctors are treating you, things are becoming better, you will be all right, soon we'll remove this tube from your mouth. So this kind of reinforcement to the patient helps a lot.
That's very important to know. People, please understand, if someone is on ventilator, it is for betterment of him, for his recovery. Someone is on ventilator because he is critical or he is sick. So family also has to support the patient. Family also has to support the doctor or the treating team. So that the recovery is faster. Today Dr. Rajesh came for discussion, and he has in simple language he has explained what is ventilator, how does it work, what are the benefits, what are the side effects, and what you as a relative can do if someone is on ventilator. He has cleared so many myths related to ventilator. Please, if you have any questions related to the ventilator or today's discussion, you can put it in comments. You can share this with someone who needs to know this, who needs to understand this, and subscribe to our channel. Thank you, Dr. Rajesh, for coming today and clearing all this.
Thank you.
Thank you very much.
You.
Yeah.